Welcome to Fluorescene.
Hi, welcome to Fluorescene episode 25. I'm your host, Dr. Alan Glazier. Now, don't forget to subscribe to the channel for updates on new shows, new segments, and other things we post by clicking that red button. It's right down there. And for notifications, click the little bell as well. Now, this week in ODs on Facebook, a doc posts about this happening. Patient says, I need to schedule my 1-week cataract post-op. And the staff says, excellent. We can see you on Tuesday. The patient asks, well, can I come in the morning? And the staff says, we open 11 a.m. on Tuesdays. The patient says, can I come in earlier than that? I'm leaving for vacation that day. Well, the staff says the doctor doesn't get in the office until 11. So the patient, well, can't the doctor just come in earlier to see me? Okay, what is it about patients and entitlement? If you could get inside their heads, you'd hear things like, come on, doc. It's not like you have anything else better to do, and I'm so special. Or, you exist to serve me. Or the receptionist could have responded tongue-in-cheek with, yes, absolutely. Would you like his home address so you can have breakfast with him and his family? Then there's a doc who said they had a patient who they called to let know their glasses were in. The glasses had been sitting there for about a week, just to let you know. Patient calls to find out when they close, says she can't get there by then, and she's leaving for vacation again. So, can we drive them to her? Yeah. Then there's the time where the doors are closed before opening, or maybe lunch hours of operation, clearly posted, and those patients who knock, often aggressively, yelling through the locked door, are you open? Boom, boom, boom. Well, doors are locked. And we're frantically trying to finish up so we can go to lunch or go home. But by all means, come on in. Now's the perfect time for us to troubleshoot your quarter diopter change. Maybe if I thought for a second that these people would be grateful, I'd consider this every once in a while. But age, wisdom, and experience has taught me that people will walk all over you if you don't set firm boundaries around your opening and closing hour. Now, in the Parent of the Year Award department, one of my favorite departments, a doc posts about a 14-year-old boy who was playing rubber sword tag in the dark on the basement on the 4th of July. And guess what happened? The conversation with the parent went like this. The mother went like this. Doc, well, he has anterior uveitis, hyphema, 2 iris tears, and a retinal hemorrhage. So far, the mom's eyes well up, and the doc says, it'll be okay. I believe he'll recover just fine. I'm so glad you ended up bringing him in. And the mom says, oh, no, doc, that's not it. It's just that, are you saying he may not be able to play in his baseball tournament this weekend? Well, when the father was brought into the conversation, it was even worse. His attitude was, so? It's just his eye. It's times like these I try to think of those mammals, you know, the ones who toss their babies at predators so they can escape. Remember, you can't be a bad parent if you don't do any parenting, right? Now, an OD asks his colleagues, which one of you fools has your patients wear their glasses as you bring the phoropter towards them? Docs posted every single day. Ugh, we hate this. It's like an eye exam lane. It's not a drive-through car wash, right? Then there are those who ask if they should open their eyes behind the phoropter. And then there are the patients who put their foreheads, yes, in the chin rest. It never ceases to amaze me, especially how myopes ask questions like they've never had an eye exam before, haven't done it 100 times, and don't know what to do each time. Now, a doc brings up when you're trying to take entering acuities, and the patient asks if they should take their glasses off. Well, one doc had a great response for this. He said, leave them on. Let's make it a fair fight. Now, we've got a great show for you today. Dr. Jeff Walline is here, who currently serves as chair of the Research and Graduate Studies Committee, as well as the Association Dean for Research at the Ohio State University College of Optometry. Now, Dr. Walline has been a principal investigator in multiple influential studies in everything from pediatrics to contact lenses to keratoconus, just to name a few. And he's considered one of the world's leading experts on myopia control. We welcome back Dr. David Kading and Dr. Brujic with another episode of Optometric Insights. and our segment with compelling clinical images from the past few weeks in ODs on Facebook. Now remember, I put a QR code in there so you can scan the QR code on each image. It'll take you right to the discussion thread with that image in it so you can read more about the case and or share your insight. Now, sit back, pour yourself something, as long as it's not fluorescene, on your patient's white pants, and enjoy today's show.
All right, I'm here today with the illustrious Dr. Jeff Walline. Dr. Walline received his Doctor of Optometry degree from the University of California, Berkeley School of Optometry in 1996, his master's degree in physiological optics from the Ohio State University College of Optometry in 98, and completed a PhD degree in vision science from OSU Optometry in 02. He currently serves as chair of the Research and Graduate Studies Committee and Association Dean for Research at OSU. Dr. Walline also founded the Kids Contact Lens Clinic at the OSU College of Optometry. He's been a principal investigator in multiple influential studies on pediatrics, contact lenses, and keratoconus, to name a few, and he's considered one of the world's leading experts on myopia control. He served as study chair of a multi-center clinical trial sponsored by the National Eye Institute and was awarded the largest industry-sponsored grant ever conducted at the Ohio State University. Dr. Walline is a leader in conducting peer-reviewed studies on myopia control, listed as author on well over 250 published articles on myopia, pediatrics, contact lenses, ortho-K, keratoconus, refractive, and other related topics. He's published several book chapters and lectures nationally and internationally. He was awarded a prestigious William C. Ezel Fellowship and a Golden Retinoscope Award, to name just two of his many honors and awards. Unbeknownst to him is how much he influenced my practice of and passion for myopia control. Now, this guy does it all, even mucin balls. Welcome, Jeff.
Thank you very much.
You know, we've met and chatted briefly at meetings. And I wanted you to know for years that I've referenced your work in my myopia control articles and my talks, and constantly come across your name when I'm researching and reading that and things I used to prepare. And it made me feel I know you much better than I really do. So I really look forward to this interview and to get to know you better today.
Thanks. I look forward to it too. I love talking about myopia and everything associated.
It's a cool topic. It really breathed a lot of life into optometry, I think. So I'm going to get right down to a really important question. Sorry to do this to you in the beginning, but you were involved in the cookie study, the cake study, the candy study. But when it came to the clip, the clamp, the blink, the Kleck study, it seems you had trouble finding some kind of confectionery to continue to name them from. Discuss.
Well, you can tell I was eating a few too many confectionaries during each of these studies, so I had to reduce my diet, and the best way to do it was by coming up with different names. But that is one thing that I don't know if it's a good thing or not that I'm sort of known for, and that's acronyms of study names. But it makes it fun. It makes the first part of the study really fun and challenging. You got to come up with a good logo, good study colors, and an acronym all to match.
Yeah, and when you're dealing with kids, it probably helps to tell them, hey, you're going to be in the cookie study. I'm sure that increases compliance to some degree. Now, question for you. At what point in your education or profession did you realize that it was going to be pediatrics and refractive and contact lens care for you?
It wasn't immediate. Actually, when I came to Ohio State, I came as a PhD student, and they asked me what clinics I would like to teach in, and I said contact lenses, and which one would I not want to teach in, and I said binocular vision and pediatrics. So I spent the next 5 semesters teaching in binocular vision and pediatrics, and then an opportunity opened up where I started teaching the pediatrics course. So it was sort of from that my research ended up following. It was actually one of these dinners at Carla Zadnik's house that I remember well. They happen quite frequently for people. It changes the trajectory of their careers. But we were just talking about, I was doing quality of life work, specifically in keratoconus, and we started talking about what else I could do for PhD. And they happened to mention, maybe a gas permeable contact lens myopia control study. And to me, it sounded perfect because at the time it sort of fit what I was now starting to do clinically, and was a really interesting, important clinical question. So that's sort of how I ended up there. And then it just sort of, it was perfect timing from there.
That's great. I'm going to get into that, actually, that gas permeable study, because that was, to me, and for what I knew and what I learned from that, was one of the pivotal studies. Pivotal studies. Not drinking yet. This is just coffee. I want you to know. So that's interesting. Back up for a second. I stopped counting at about 250 publications that you're listed as an author on. Do you know the exact number? Where is it?
I'm in publications. It's just, peer-reviewed publications. It's like 50. The other publications, I really honestly don't know.
Okay. Well, there's a lot, and that's impressive. Along the way, is there any particular study that stood out, that turned out very much differently than you maybe your confirmation bias would have thought it would?
Yeah, absolutely. The CLAMP study is the primary example of that. And the CLAMP study is a rigid gas permeable contact lens study that we conducted. Everybody believed that they slowed the progression of myopia because study after study after study had shown it. But all those studies had the opportunity for bias. And that is exactly what turned out to be part of what was showing what was happening in the studies. And the bias came from a lot of kids who are wearing gas permeable contact lenses would drop out of the studies. And there's quite potentially some connection that we don't know about, where the fast progressors also are less able to sort of adapt to contact lens wear. And so if that's the case, then it looks like you slowed down myopia progression when really you didn't. And that's what we truly found, is that we didn't slow the growth of the eye at all. And we only slowed myopia progression because we flattened the cornea slightly, even though we were documenting that we were fitting alignment fit gas permeable contact lenses.
Right. My father, who is an OD, graduated in 1963 from PCO. He always taught me that RGPs were better for patients because they slowed myopia progression. And the profession has a long history of believing things that don't have research to back them up, or maybe, again, using their confirmation bias or small n's, like what they see in their practice, to make these judgments. I always thought maybe it had something to do with just the flatter fit RGPs, and they used that was kind of the bias there, because when I started fitting Ortho-K, as you also know, we were fitting spherical RGPs flat. We didn't have reverse geometry lenses. And maybe I'm older than you, I don't know, but you know, that was a big thing. So is there some other reason that ODs maybe held on to that notion for so long?
You know, there was evidence, you know, in the peer-reviewed literature that they actually worked. It's just that they didn't have any studies that were free of losses to follow-up. They all had about 50% loss to follow-up in that group. And that's the one thing that we saw. So what we did was we only allowed kids who could adapt to gas-permeable contact lenses to be enrolled in the study. That was the difference from all the other studies. And that we had zero loss to follow up over a period of 3 years. And so that was a difference, and really what showed that gas permeable contact lenses don't slow the progression of myopia.
Excellent. Well, that was pivotal. I appreciate that data. That changed my whole practice.
Yeah.
Regarding progressive myopia, or I like to call it myopic creep, ophthalmoscopy, another word I should not have put in the interview. There's a significant contribution to Bruch's membrane, and histologically, it can appear that there's a lot of basement membrane involvement, decrease in RPE density, things like that, equatorial thinning, and focal areas of weakness in the sclera. What would you, in your research and what you've read, what do you feel the biochemical or physiological weakness is in the back of the eye that causes that expansion, or the processes underlying it?
If I knew, I would be rich. We honestly don't know.
Question.
Yeah, exactly. But really, in theory, it's just due to the stretching. You know, beyond that, really, I have no idea, to be perfectly honest. But the stretching of the eye is what seems to be related to a lot of the adverse effects of myopia and myopia progression. And what we are slowly learning is that it's not just the higher myopes that have these issues. It's all myopes. The risk is higher as you get higher amounts of myopia, but there's still a risk there even with low amounts of myopia. So we've got to do what we can to try to slow the progression of myopia in children. Even though we're not having a huge effect, we're having an effect, and ultimately, you know, 50 years down the line, that could help save some vision.
That's great. Your answers are very succinct and good. I love it. Hope I have enough questions for you today. What are the unmet needs currently in myopia research, in your opinion?
There's so many questions to be answered.
Couple on the top of your mind.
Yeah, some important ones are, you know, we ultimately want to get to individualized treatment for patients. So what is the best treatment for this given individual? We don't have a clue what that is yet. People claim to have protocols in place that will provide them with the best myopia control, but it simply doesn't exist. The studies haven't been done. I think that's one area where we need to work. We need to find out how we can optimize the signals that actually slow myopia progression. So we believe that, you know, myopic defocus is a strong signal for slowing the progression of myopia. But what is it about that myopic defocus? Is it the most myopic meridian? Is it the quality of the image? What is it about that myopic defocus that actually slows myopia progression? We don't know. We've got to try and answer those questions. You know, right now we're lucky. We have 4 options available to us: gas permeable contact lenses, soft contact lenses, orthokeratology contact lenses. We have spectacles, although they're not yet available in the US, and then low concentrations of atropine. So A, which of those is best for a given individual, and B, how can we optimize them? You know, we have some ideas that combining optical treatments with pharmaceutical, so atropine, is beneficial, but really only for orthokeratology. That's the only place we have evidence. So we've got to look for evidence in the other combinations of those treatments and see if it works. And then we know that myopia control seems to work for a short period of time, but it doesn't seem to work much after that. So should we be switching treatments every single year to try and get a better treatment effect? And that's just a few of the important questions. You know, I always Well, no, I should say I never really worried about, answering the questions and then running out of them. It seems like research always creates more questions that it answers. And so I kind of consider that to be, solidify my role for a job in research for a long period of time.
Right, right. And are you working a lot with pharmacological agents, or mostly the optical and refractive agents? Because I do have some questions on pharmaceutical stuff, but I wasn't sure if that really was a focus of your research.
It hasn't been, but I follow the literature very closely, so I can answer a lot of questions. What I submitted a grant for, the next grant that I submitted is to try and delay the onset of myopia with pharmaceutical agents with low concentration atropine. And so, we have hopes that that would be true and that it could potentially even be more effective than waiting until somebody becomes myopic, because A, you can have a large effect early before they become myopic, and B, you get them treated sooner. So that really is the next area that I want to branch out to, and at least in terms of NIH funding, and try and find some answers for our clinical colleagues.
Yeah, that's great. I remember a long time ago in my research, not doing research, but reading and reviewing research, was where they were looking into dopamine as having a role. They went back and forth over the years about dopamine, and I think that there is some role there, only because the two things we know through the peer-reviewed research that work really well like you said, lose their effect. And it's very similar to what happens dopamine in many treatment courses, is over time it loses its effect. Mm-hmm. So I think ultimately they may find that at the bottom, the root cause is some type of chemical pathway related to dopamine, although hasn't been elucidated yet. I know just recently, in the past couple of years, they were looking at a new medication called 7-methylxanthine. Mm-hmm. It was a new hot topic a couple of years ago. I haven't heard much lately. Are we anywhere with that? Have you heard anything about that?
I haven't heard anything promising on the horizon, so I really don't know, but I know that people are still studying it. I'm always curious because I'm a 5-diopter myope, and 7-methylxanthine is actually a caffeine derivative, and I drink lots of caffeine and it hasn't helped. No, I hate those personal anecdotes, to be perfectly honest, but it really remains to be seen. There just isn't much evidence, and what evidence that is there really hasn't been all that strong, to be honest.
All right. Well, the next study, then the next grant is for caffeine eye drops.
It will have to look at the side effects, especially if they're in children.
Right here on the Fluorescene Show, we came up with. That's great. I'll help you with that one. So you had mentioned backing up a second. So you had mentioned the temporary effect of ortho-K, among other things. What is the current understanding of how long ortho-K benefits last in the children? So for our viewers, they can give their patients some good information.
Yeah, most studies are only conducted, basically orthokeratology studies have been conducted over 2 years. There haven't been very many that have gone beyond that. And they've been beneficial for the most part 1 to 2 years, some 1, some 2. But there was one 5-year study that was done that actually found additional benefits through 3 years, and then not over the 4th and 5th year. But in all of those studies, there's been larger amounts of dropout as you go along, of course. And so a lot remains to be seen in that area. But that was at least an indication that possibly the optical methods of myopia control might last a longer period of time. But that really remains to be seen.
I never having an answer based on research for my patients, I always told them that I thought it was wise to continue, because the common question is, when should my child stop? And I always told them, I feel it's probably prudent to use it through their growing years, and then we can reevaluate, try other methods. And then if they start slipping, go back to it. And so that's kind of how I handled that.
That's exactly what I say as well, but it's based on, clinical intuition. It's not based on evidence yet. So we've got to, that's yet another question that we've got to try and answer long-term. It is funny how we are so anxious to take people out of myopia control treatments. And I don't really know why, because they don't have all that meaningful of side effects. People are doing really well in them. One of the things we're taking a look at now is, if you fit kids with soft multifocal contact lenses, will it ultimately harm their accommodation? And so, if that's the case, then of course I see why you'd want to take them out of, soft multifocal contact lenses as soon as possible. But if that's not the case, then I don't really know why we ever would. Let's ease them into presbyopia at age 35, 40.
So harm their accommodation. You mean from a binocular standpoint or from actually changing the physiology of the lens?
Well, some people fear that with a bifocal contact lens, these kids aren't going to be accommodating. And so if you don't use it, you lose it type of theory.
Right.
But, and there is conflicting evidence. Some evidence shows that kids still accommodate even with multifocal contact lenses, and some evidence shows that they have much less accommodation with multifocal contact lenses. So it really remains to be seen. And luckily, in the Blink study that we conducted, because of the pandemic, we ended up basically following a lot of kids for 4 years in their randomized treatment. And then at that time, we put them in a new study. And so at the baseline of that study, we'll measure their accommodative abilities. And so we'll have a strong idea of whether or not it does actually affect accommodation.
Interesting. I think the accommodation itself is a role of the rigidity of the lens as presbyopia ensues. I wonder. I doubt that's going to have an impact, but it'll be interesting to see. Very interesting. Since 2002, there have been something like 170 reviewed articles on myopia control published, maybe more. If you had to boil it down into an elevator pitch, what would you say that those studies said about myopia control?
Yeah, I'd say those studies say that we have basically 4 options for myopia control right now. Again, low concentration atropine, orthokeratology, soft multifocal contact lenses, center distance design, and special myopia control spectacles. So we're at a place where we have lots of options for our patients and should be able to fit our patients with some form of myopia control.
Great. I wanted, you brought up the spectacles. I had a question here in red that I was maybe not going to ask, but since you brought it up, there are several on the market, several attempts to creating these lenses, and the optics, of course, are not fixed in relation to the eyeball. What do you see some of the limitations or some of the benefits of the ones that are coming out now, the ones you know about? Can you discuss that?
Yeah, so the ones that are coming out that are available worldwide, except for the US, basically, are MyoSmart lenses. And they have these little 1 millimeter lenslets all throughout the mid-peripheral part of the lens. In the center part, it's clear distance vision. And you would think that looking through those little 1 millimeter lenslets would be like looking through, rain on the windshield, for example. But I've actually experienced them, and when you look through those lenses, yes, there is a little bit of blur, but it is exceedingly minimal. So, I think that kids can wear them even for sporting activities. I think, I wouldn't recommend taking them off for sporting activities or anything like that. I'd recommend full-time wear with them. And in the one study that was done, only one study's been actually published, but it found a very meaningful slowing of myopia progression, right along the lines of what was found with MySight contact lenses and what, some of the best results in any of the studies. So I think there is promise, but of course we need replication of that one study that was conducted, and there's at least another lens that's coming out that's similar to that one, similar in design, that shows promise. So fingers crossed.
That study was, correct me if I'm wrong, it was conducted by the company.
It was sponsored by the company, but it was conducted by Hong Kong Polytechnic, and Carly Lam was a primary author on it. And I think it was a well done clinical trial. I really believe the results that they reported.
It seems that in the studies where the ones that are showing a positive effect for all these modalities, around 50% is really good, right? Is where we're seeing them, the ones that work land around 50. I've even seen as high as 60, as low as 40%. So somewhere in that neighborhood. That's great.
Yeah.
So can you mention or talk about a few ongoing evidence-based interventional studies in myopia control that viewers might want to pay attention to? It doesn't have to be just myopia control. It could be any of your areas of interest.
Good question. I can, the next study to come out with the second spectacle lens, I think will be very important because it'll show us some replication, slightly different design, but at least it'll show us that spectacle lenses truly are an option for us. I think people are looking at all sorts of different questions related to atropine. So atropine is an irreversible muscarinic antagonistic receptor antagonist. And exactly. And so it basically what has to happen is the receptor has to go away, and that takes about 2 weeks. So we shouldn't have to give the drop every single day and it still maintain its effect. So the question is, can we just give the drop on weekends like we do for amblyopia or something like that? So I think that's an important question to come up. And actually there was one study that was done with 1% atropine where they put the drop in one eye on, we'll say, the first of the month, and then they put the drop in the other eye on the 15th of the month, the first drop in this eye on the first of the next month, etc. So just one drop per eye per month, but alternating them. And what they found was that it slowed myopia progression, axial, and eye growth by about 80%. So, I think looking at low concentration atropine will do that as well. Now, what that effect will be on compliance, I don't know. I don't know if it'll improve compliance or lower compliance because you forget about taking the drops every 2 weeks. It'll be interesting to find all that out if it does turn out to be effective. But I think that's another area. And then I think one of the big questions right now is, can we delay the onset of myopia? We're not going to prevent it. A lot of people call it prevention. We're not quite that powerful, but if we can just delay the onset, in theory, that will keep us less myopic as adults, because we know that the younger the onset of myopia, the more myopic you are as an adult. So if that's actually found out to be the truth, I think we can have truly a bigger effect than we do with myopia control. So lots of things on the horizon, lots of important questions to be answered.
Oh my gosh, yeah. And just for the benefit of the viewers, the last time that I looked into it, the recommendation for atropine was between 0.025% and 5%. And that study, talk about that study and what it told us so people can adjust their clinical recommendations.
Yeah, so in that study, they randomly assigned kids to 0.05%, 0.025, and 0.01. And found that the best myopia control was with 0.05%, but without additional side effects. And the way I'm sort of measuring side effects, it was a creative thing they did in the study. They gave kids single vision clear lenses for glasses to wear while they're taking their atropine eye drops. But they told them, if you are photophobia, let us know, we'll change your glasses. If you can't see it near, let us know, we'll change your glasses. About 30% of the kids on 0.05% atropine were photophobic and needed photochromic lenses. And so it sounds like atropine really makes you more photophobic, but 40% of the kids on placebo actually wanted photochromic lenses. So what that really tells you is either kids like photochromic lenses or kids in general are photophobic, but the atropine doesn't increase it. And then basically no kids needed the progressive addition lenses to improve near vision. So to me, the clinical effects are very meaningful, or very, very small, I should say. And but the progression is slowed most by 0.05%.
Sounds like adults, like in clinic, 50% of the adults want photochromic and 50% don't. I'm making those numbers up, but it doesn't sound much different than adults.
Yeah, either they think it looks cool or they just are light sensitive. And so I completely get it.
Sexy new toy until they realize there's a tint in their lens, a lot of time indoors, although that's been relegated to the past as well. That's interesting. I know what a huge news it was to myopia control having the MiSight and the FDA approval on that. It drove a legitimacy to the clinical practice of myopia control. And I imagine that the next big jump like that will be when it's confirmed that the eyeglass technologies do that also, because that will open myopia control up to children of all ages. Mm-hmm. Whereas before, contact lenses under a certain age were very difficult to manage for the kids.
Yeah, I think the age range though is 8 to 12 for the MiSight contact lens. So it gets pretty young, because in the US, kids generally become myopic at age 8, 9, or 10. So it basically covers the range. But where I think that FDA indication is most important is now the companies can talk to parents about this. So the word can get out to people who aren't going to their optometrist, or it adds a second voice to the optometrist recommendation for myopia control. And that's, to me, the important part of an FDA indication for myopia control, because companies prior to that indication couldn't say a thing about myopia control. But yeah, and more that in terms of legitimacy, I think that comes from the scientific evidence, and there's a lot of scientific evidence out there that we can slow myopia progression. And so I think practitioners, that's not the only option that they have. You can still prescribe things off-label. It doesn't put you at any higher risk of legal problems or anything like that, because the scientific evidence is still there. So really, the FDA indication is important, extremely important, and I think it's important to be first always. But also, we get the word to parents more. So I'm couldn't be more happy for that FDA indication.
Yeah, I strongly believe that there will be a time in the not too distant future where myopia control options are standard of care for youth, for children and up to a certain age. What is optometry going to look like when standard of care it becomes myopia control instead of single vision?
We will finally be acting like doctors. All we've done is treat the symptoms and haven't done anything to treat the disease. Now we will be treating the disease, and I really, that makes me happy. I also, that's one of the reasons I actually like atropine as a treatment for myopia control, is because it follows a medical model. When our patients need atropine, right now we can only get it from the compounding pharmacy. So we are actually sending the prescription to the compounding pharmacy, who sends the medication to the patient. The patient comes back to us for care. So we're sort of following the medical model that we purport to follow. And so, I think it only strengthens our foothold in the medical model of optometry. And so for that reason, that's why I think myopia control is that's another reason I think myopia control is really important.
I love that. I love that. And not being standard of care right now, there are no legal implications to not recommending it. And the problems from it are developed so far down the road. I don't know that there ever will be. I just hope that our colleagues get on board with it, because we do know that there are significant implications for public health, for personal health, as people age and get more myopic.
Yeah, and I think we really are. I basically think it is the standard of care right now. I know not everybody's practicing it yet, but they need to get on board and start practicing it, because you got to at least talk about the options. You can allow, or the parents don't have to choose them, but you got to tell them about them. And so I really think we're at the place where I don't honestly know what ultimately makes something the standard of care, but we've got to be as close as possible if we're not there already.
Right. I feel like in the exam lane, when I'm evaluating a young child that's a child of two myopic parents, and let's say in this example, the mother is sitting across the room in a chair while I'm doing the testing, looking at her phone. In the back of her head, she's expecting me to tell her there is a change there. As she grew up, there was always a change. There was never a time where she didn't have to change her glasses or lenses. So she's expecting the same for her child. It's up to us to break that mold, to educate and to teach parents that the paradigm has shifted, that I don't mean to use that term lightly. Everybody uses paradigm shift, but this is a real paradigm shift in the way that parents need to think about what's best for their children. Things change, and the way it was for those parents doesn't have to be the way it is now. So we have to take the time to have that conversation in the exam lane. And I find that's the most time consuming part of myopia control, is trying to convince the parents what's best for their kids when they have this idea of what normal is that has changed.
Yeah, absolutely. But the one thing that we have to keep in mind is that because optometrists don't think of refractive error as a disease, there's no way insurance companies are going to. And insurance companies don't cover myopia control. And so it has really become a treatment for the privileged. And so we've got to think about, as we go along, how can we provide this to the underprivileged people who also deserve the same benefits that everybody else gets. So, that's where, to me, that 1% myopia, that 1% atropine given once a month, basically in each eye, may ultimately be important because that would lower the costs. But I don't know what the spectacle treatments are ultimately going to cost, but hopefully they're maybe more affordable some other treatments. So we've got to figure out ways that we can provide the care to all of our patients, not just those who are advantaged. And that's a big thing that I think we got to tackle going forward, because myopia control has become a premium in practices, and we aren't thinking about the people who can't afford that premium.
Right. One more clinical question, then I want to wrap up with a couple personal questions. This isn't even a question so much as something that I wanted to draw attention to, and I thought having you talk about this would really help drive the message home. Sorry to ODs. It's been a rough throat week. When you more ums, how do I ask this question? So patients, even doctors, still are undercorrecting people, thinking that, again, small n's and belief systems, that's better and is a driver for slowing down myopia progression. We know that's not true, and actually may even worsen things for people. Can you talk a little bit about that and those studies and help convince our viewers who aren't already on board with that undercorrecting is not the right thing to do?
Yeah. You need to be practicing evidence-based medicine. You should not be practicing based on your beliefs. When the evidence is out there to show that it simply doesn't work, you should not be doing it. So not only are you not providing your patients with the best vision, but you're not providing them with myopia control. And like you said, could potentially be making myopia progression worse. I'm not sure that that's a significant thing, at least not clinically meaningful, but at the very least, you're not helping them, and you are providing them with suboptimal care. So we absolutely should not be providing our patients with undercorrection, because it's just not an option. Especially since it doesn't cost any more for the patient. It's just crazy not to fully correct patients. The other thing that we shouldn't be providing our patients with on a routine basis is multifocal spectacles. They've been shown over and over and over again not to work. If none of the other options worked and you still wanted to provide something, I get it. But that's such a rare occasion that they just should not be even in the conversation for myopia control. There's so many other options available to us today. Things have really changed. There's evidence to show there are other treatments that are available. We've got to get out of our, old beliefs that, gas permeable contact lenses work, multifocal spectacles work, undercorrection works. They just don't. Get them out of your lexicon when talking to parents.
Right. I think a study showed a modest effect in isophores only for a high set 35 millimeter seg of like 11%. But when you have options that can provide 50% effectiveness, it's irresponsible to recommend that as a first option if the other options are also available to them.
Right. But even for those isophores with accommodative lag, there was a study, a randomized clinical trial that was a follow-up to where that information came from. So that information originally came to looking at subgroup analyses in the COMET study. And they found that the bifocal glasses worked best in the isophores with accommodative lag. So they did a subsequent randomized clinical trial that, for whatever reason, people tend to ignore. That randomized clinical trial found that small subset of patients didn't get any additional benefit. They still got less than a quarter of a diopter benefit over a 3-year period. So even for those isophores with accommodative lag, bifocal spectacles just don't help.
Excellent. Thank you. Taught me something there I did not know. That's great.
Yeah.
So let's move on. What are your passions outside of optometry?
I do something called Zentangle, which, I wanted to do something artistic and I had no idea what it was because I'm not artistic. But Carla Zadnik actually gave me a little book called Zentangle, and it's the art of doodle. So it's literally doodle art that, people have taken in many different directions, and I love to do that. I don't practice the Zen side of the tangling. I just practice the artistic side. So, I carry little cards with me. That's what you do it on. And when I'm bored or when I want something else to do, sometimes I pull those out. And so it gives me a way to practice my artistic side and to get away from, science or whatever crazy things going on at the time, and just concentrate on not concentrating, basically. And so that's really what I do. I used to teach spin and I loved it, but during the pandemic, the gym shut down and I haven't gone back to it. And so I haven't been doing that, but that's basically my outside of optometry pastime.
You know what the next question is? Show us a doodle.
I don't have any on me. I followed Amy Acton. She's our public health agent. I follow her closely because she said, don't bring anything to work that isn't necessary. And this was back when the pandemic was at its height, but I stopped bringing my shoulder bag with me to work. And so when I went to AOA at the meeting where we met, my shoulder was killing me just because I'm not used to carrying my bag around. But that means I also don't carry my Zentangle around constantly with me. Otherwise, I normally would have it here.
Well, if you email me one, I'll put it in the show. Love to show people that. I think they like to get to know you better that way. It's funny because I know someone who does that, which I never thought I would hear that out of your mouth or anyone in my profession. So he does some really great stuff. I'll see if I can connect you on Facebook just to see his
yeah,
incredible. Very thought provoking. And again, wonderful stuff. So tell us about your family, your friends, your pets, anything you want to tell us about.
Well, I almost feel guilty because my partner and I made it through the pandemic easily because we don't have kids and we don't have pets. And so, as much as I hate to say it, the pandemic didn't hurt us that bad. I still worked from home every single day. He still worked. And so we didn't have a lot. He and I are opposites in every way possible. He's the introvert. I'm the extrovert. He's the musically talented. I am the musically talented. And so opposites attract, and it works really well for us. So that, Phil.
Phil, great.
Yeah.
What does Phil do? What's his profession?
He's a music director in a Catholic church.
Oh, there you go.
So
yeah, music and the creativity.
Oh yeah, absolutely. He's starting a handbell choir with his group. He directs the choir. He plays the organ. He plays the piano. A quick story about him. We went out. We were shopping, and I don't know why we were in a music shop, but we were. He randomly bought a flute, and I still don't actually know why, but he did. And he had never played the flute before, but within an hour, he was playing music on it. I couldn't get a tweet out of it, and he was already playing music. I mean, the fingerings, he had done woodwind, so he gets a little bit of that, but how you could play music out of a flute within an hour, I don't know. And when he grew up, I think sold a few sheep to get a little organ for home. And within 6 months, he was playing at the Easter service at his church. So it just comes natural for some people, and it doesn't come natural for others.
Yeah, some people can play by ear, and
yeah,
if you give them enough time. I can do that. I can play by ear. Every instrument I've tried, except for two, a trombone and an oboe, I could do something on in an hour. But I grew up playing classical piano, and so I don't know whether it's the ear thing or I learned really young, but that's wonderful.
It's not something that I understand at all. He keeps claiming he can teach me to sing, and I keep telling him that's a challenge you don't want to try to meet.
Suffer for punishment, sounds like. He'll leave well enough alone. Anyhow, maybe next pandemic he can do that, right?
Maybe.
God forbid. So listen, Jeff, it's been great having you here. I had so many more questions, but again, I respect your time, and it's getting close to a half hour, if not over. And would you be willing to come back at some point when there's updates and new stuff to talk about?
I'd love to, anytime.
Great. I appreciate you, everything you do, everything you bring to the profession and society as well. And I look forward to seeing you in Boston, probably next at the Academy.
And research is useless unless the word gets out. So thank you for getting the word out. Really appreciate that.
It's a passion of mine. Glad I could help. And again, thank you for joining us on the Fluorescene Show today.
Thank you.
All right. Have a great one.
Hi, I'm Dr. Alan Glazier, and welcome to this week's Fluorescene News. In pediatric and amblyopia news, researchers conducted a randomized trial to compare effectiveness of combined atropine and patching therapy, or CAPT, C-A-P-T, versus patching alone in children aged 3 to 12 years with severe amblyopia. CAPT, or patching therapy, were randomly assigned to participants aged 3 to 12 years with severe amblyopia from 2100 to 2500 caused by strabismus, anisometropia, or both. Among 108 candidates, CAPT resulted in greater mean improvement of amblyopic eye visual acuity than patching alone among trial participants, though the clinical significance of this relatively small VA difference cannot be determined from this trial. In pediatric myopia and optic nerve news, a study observed the optic nerve fiber layer thickness and blood flow density in the papillary area and investigated the effects of axial length and the refractive state of the optic papilla blood flow density in children with different refractive conditions. The study revealed that as myopia increased and the axial length grew in children, the blood density of the optic papilla in the disc and retinal capillaries in inferior papillary, parapapillary, and temporal quadrant would change significantly. With increasing axial length, a significant decrease in intradisc and paradisc retinal nerve fiber layer was observed in the superior, nasal, and inferior quadrants, while a substantial increase in RNFL was observed in the temporal quadrant. In optometric scope expansion news, the Mississippi State Legislature passed Mississippi House Bill 1302 on March 17th, went into effect July 1st to expand optometrists' scope of medical procedures. According to the bill, optometrists who pass the Board of Optometry test can perform optometric YAG laser posterior capsulotomy procedures, minor surgical procedures, and prescribe certain things. More than 140 optometrists in the state took the certification exam. Hey, congratulations, Mississippi. Thanks to the Mississippi Optometric Association and everyone who came together to make this happen. Nothing makes me happier than moving our profession forward. In retinal news, a joint research team led by Severance Hospital has developed an algorithm that predicts the risk of new cardiovascular diseases by observing changes in blood vessels in retinal images. The artificial intelligence-based algorithm uses coronary artery calcification index to predict heart disease, including cardiac infarction or angina, more effectively without exposing patients to radiation. The research team used digital retinal images to develop the algorithm to determine the correlation between the coronary artery calcification index and the retina. They determined the presence or absence of coronary artery calcification by applying deep learning techniques to 216,152 retinal images in 5 data sets from Asia and the UK. In glaucoma news, NICOX presented results from the Dolomites Phase 2 clinical trial showing that NCX-470, a novel nitric oxide donating prostaglandin analog, produced significantly greater intraocular pressure lowering effects in glaucoma patients compared with the current standard of care, latanoprost. In the Dolomites study, which evaluated 3 concentrations of NCX-470 compared to latanoprost 0.005% in 433 patients with open-angle glaucoma or ocular hypertension, NCX-470 achieved superiority compared to latanoprost 0.005% at all time points on day 28 with up to 1.4 millimeters of mercury superior IOP lowering. NCX-470 was safe, well tolerated, with no drug-related serious adverse events and no evidence of treatment-related systemic side effects. The presentation of the results was during the World Glaucoma Congress of 2021. The Dolomites trial was completed in 2019. In keratoconus news, epithelium-off cross-linking has long been established as the gold standard treatment for progressive keratoconus. Several protocols for epi-on CXL have been proposed to help reduce post-operative pain and facilitate visual recovery, but there's no epi-on treatment approach currently approved in the United States. The hydrophilic and macromolecular characteristics of conventional epi-off riboflavin formulations may create clinical challenges for absorption through an intact epithelium. A study investigated the clinical efficacy of a dextrin-free hypotonic riboflavin ophthalmic solution called Photrexa by Glaukos. It's approved for epi-off CXL in a novel epi-on CXL protocol. The research concluded that patients who underwent epi-on CXL with dextrin-free hypotonic riboflavin demonstrated improvements in uncorrected and best-corrected visual acuity with stable keratometry at 12 months post-op. The efficacy is consistent with other epi-on studies to date, but remains lower than standard epi-off CXL. New technologies, including supplemental oxygen and transepithelial riboflavin ophthalmic solutions, are currently under clinical evaluation and may offer a path forward for epi-on CXL in the USA. In AMD news, a research team from France has identified a blood biomarker that can predict retinal levels of omega-3 fatty acids. These results, published in Clinical and Translational Medicine, open new perspectives for the dietary prescription of risks related to the disease. By analyzing retinas and blood samples from 45 human donors, the scientists were able to identify the blood biomarker for retinal omega-3 fatty acid status using an algorithm developed by machine learning. They then combined the analysis of retinas from human donors and the data from 2 population studies. The scientists were able to show that high levels of the blood biomarker were associated with a lower risk of having an advanced form of AMD, and that biomarker levels rose after omega-3 fatty acid supplementation. At a very early stage, this biomarker would be able to identify people at risk for developing AMD before it can be detected by ophthalmological examination. Once identified, at-risk individuals could thus receive dietary support. And that's all for Fluorescene News. Now, on with the rest of the show.
Our presbyopic patients are those that are most likely to require refractive correction. Yet, as we look at the number of contact lens wearers in the US, it decreases as patients age. When we take a look at our presbyopic patients, it's remarkable that 92% of them are wearing glasses to correct their vision. And only about 8% of presbyopes are wearing contact lenses. Of that 8%, 2.2% are wearing multifocal contact lenses, 2.3% wear distance contact lenses with or without reading glasses, and 3.5% wear a monovision strategy. One of the major reasons for the relatively low amount of presbyopic contact lens wearers is that the quality of the tear film tends to be less viable in the presbyope. This compromise in tear film quality can ultimately lead to less comfortable lens wear. In fact, when patients who have discontinued contact lens wear are asked why they stopped wearing lenses, over 50% report uncomfortable lenses as being the primary reason. In previous episodes, we discussed the importance of the ocular surface assessment to identify patients who have compromised ocular surface health that could lead to a suboptimal lens wearing experience. Please refer to previous episodes for summaries of a number of the tests that can be used to assess the ocular surface. A new technology has been recently approved, the Inflammadry. It actually measures matrix metalloproteinases. Matrix metalloproteinases, or MMP9s, are nonspecific inflammatory markers in the tear film. We know that in dry eye patients, the levels of MMP9s are elevated. Inflammadry determines whether there is more than 41 nanograms per milliliter of MMP9s in the tear film, which seems to be a critical number to differentiate the normal from abnormal tear film by sampling a small quantity of tears. Consider incorporating a point-of-care test such as this to help assess the quality of the tear film. Remember that contact lens wear drops off rapidly in our presbyopic patients. The quality of the tear film decreases in the presbyopic age category, and this is likely contributing to some patients dropping out of their lenses. A comprehensive ocular surface evaluation will be critical to identify those with compromised ocular surface wellness, and new point-of-care tests may help us identify those patients whose ocular surface needs to be managed to optimize lens wearing experiences. Ultimately, this will help more of our presbyopic patients interested in wearing lenses do just that.